Good afternoon, everybody. Welcome to Grand Rounds today. Today, I have the pleasure of introducing Dr. Jonathon Geisinger. Dr. Geisinger is an orthopedic spine surgeon. He attended medical school at the University of Iowa, did his orthopedics residency at the Beaumont Health System just outside Detroit, and his spine fellowship at the Twin Cities Spine Institute. And he has kindly accepted our invitation today to give us a review of cervical myelopathy and lumbar spondylolisthesis. And please join me in welcoming Dr. Geisinger.
Yeah, thank you for the opportunity to present. And if you're tuning in later, thanks for tuning in later to catch up on this topic. So this is a topic that's very near and dear to my heart. It's an important topic, a topic I treat very commonly, and it's one of those things that's very unique in terms of I can really sometimes change the whole course of somebody's life by being able to decompress their spinal cord and give them a whole new take on life and the abilities that they can do. So before we get into the details of cervical myelopathy, I wanted to kind of give you a little background of where I came from, and I'm originally from Northwest Iowa. My family farms up there, and that's me in the picture on the right with my middle child, Atlas, and that was just last weekend we were up there combining, so I think they're wrapping up in the next day or two here. Spencer, Iowa, that's pretty well known for the Clay County Fair, so if you're from Iowa, you've probably heard of that, and one of my favorite things to do every year is to go up to the Clay County Fair in September. So from there, I went to the University of Iowa. I spent 4 years in undergrad and 4 years of med school, and from there, I went out to Royal Oak, Michigan in the Beaumont Health System, which is a huge hospital, a level 1 trauma center out in the northern suburbs, and just a phenomenal hospital, 50, 60 orthopedic surgeons, and just a lot of operating rooms and a lot of great experience out there working with these attendings and training. It's actually so big, even as a private institution, that it has its own animal research department and really just a huge research department. So while I was out there, I did a lot of animal studies, and one of the big studies I was involved with was this sheep study where we looked at putting stem cells into ACDF surgeries, and that's an X-ray in the middle of ACDF procedure that I was doing on sheep. And we looked at stem cells and increasing fusion rates and things like that, and just really, really grateful for that opportunity and that cool research I was able to do at that facility out there. From there, I went to Twin Cities and did a year-long fellowship there dedicated to spine. And Twin Cities Spine is a very large and historic spine centers and really one of the biggest spine centers in the country. And the picture on the left there, the gentleman in the middle, is Dr. Moe. And Dr. Moe worked very closely with Dr. Harrington and spent a lot of time with Harrington coming up to the Gillette Hospital, and you've probably heard of Harrington rods. And so orthopedics has had just a really rich history in taking care of kids with deformities and scoliosis, and going on to develop a lot of the spine procedures that we do now for cervical, thoracic, and lumbar spine. So from there, I went to Sioux Falls for 3 years in private practice and at Orthopedic Institute, and that's a picture of my family there on the left. And, we had a great time in South Dakota, but McFarland Clinic was something I looked at out of training, and unfortunately, I was able to make a transition here recently about 5 months ago and come down and join all the wonderful colleagues I have here now at the McFarland Clinic. And I just have to thank everybody. It's been a wonderful start to the clinic here and a practice, and I feel really fortunate to be a part of the McFarland Clinic and the hospital here. So with that, let's look into cervical myelopathy, and I can break this down into some different things as we kind of march through this presentation. First, we'll look at the anatomy of the cervical spine. We'll look at the pathology, the different causes of myelopathy, how to diagnose it, look at some imaging, the different treatment options for it, and then also review some cases. So anatomy is very, very intuitive and important to me in terms of it's really the foundation of how you understand a lot of these disease processes. So I have this really, really incredible app where I'm able to go in and look at different views and things and take segments out and really get a detailed look of the exact anatomy. And so that's something I wanted to share with you with this presentation. And so you can see just kind of understanding some of the initial anatomy of the cervical spine is I took a vertebra out, and you can see the nerve coming down from the side, and this is the spinal cord in the middle that's encased in the dura there. Another view of it here is looking at the front. So if you're looking straight on at the spine with that same vertebral body segment that's taken out with the nerves coming down to each side with that protective coating, that dura that sits over the spinal cord and the nerves. Zooming in a little bit closer here now, you can kind of appreciate the disc. And then in the middle is this kind of gelatinous material, and sometimes we refer to it as kind of like a jelly donut, where you have the disc, the shock absorber material in the middle, and sometimes people get disc herniations where that comes out. And that material in the middle, it's actually more the consistency of crab meat, but as people age and get a little bit older and a little less hydration in the disc base, it does kind of start to desiccate and get more flaky as well. Another view looking at the spine. You'll have to bear with me here. Again, I love the anatomy and I love all these images I'm able to recreate, but I think it really helps you understand the foundation of what goes along with myelopathy in the slides to come. And so you can see just the close proximity of that disc right over the spinal cord, and just how close it is when a disc or when you have any degeneration where it can come out and start to hit onto the spinal cord. That white shiny thing right in the middle, now that's the posterior longitudinal ligament, which is this right here. And that sits right over the top of the dura and right in front of the spinal cord. And another view, this is looking at it from the side. And if you look at it from the side, it's this ligament right here that sits really, really close proximity to your spinal cord. So cervical myelopathy, kind of the pathology and what it is when you have direct compression that pushes right on the spinal cord. And these images on the right, or this image on the right, shows you this disc bulge or this degenerative material where it's pushed back into the spinal cord, and so much so that it caused it to start turning white. Now, when this happens, that whiteness is actually edema or swelling that's going on inside the spinal cord, and that's from scarring and also the demyelination process of when the spinal cord is under such severe stenotic conditions. Couple mechanisms for this is people think it's either the direct compression that causes that scarring versus the decreased blood flow, which just makes sense. If something's tight, it's going to be harder for blood to flow into that area to keep it vibrant. So again, this relates back to the anatomy. When you look at it from the side, with that posterior longitudinal ligament being this thin slice right here, and if you go over and look here, you can see how that's just in extreme close proximity to the spinal cord, and it really is just sitting right on top of the spinal cord, pushing into it. This is an image that I created where I could go in and put bone spurs in there. And this is essentially what you do when you need to take care of this, is you go in and you identify these bone spurs, and you're able to get behind these while respecting the spinal cord and take down these bone spurs and things that are pushing on the spinal cord. So causes of myelopathy, there's several different causes. The end result's kind of the same, right? Pinching of the spinal cord. You can have developmental, just something I kind of explain to people sometimes is some people are born with really, really big spinal canals. And I say it's like a 4-lane interstate, and they could have all the degeneration in the world. They could all have all the disc bulges or all the bone spur formation, and they just don't get any neurologic impingement because they have such big spinal canals. Unfortunately, some people are born with a 1-lane highway, and if they get any kind of disc bulge or any kind of bone spur, it can push right on the spinal cord and start giving people symptoms from it. So developmental, having a small spinal canal is an important part of what leads to myelopathy in some cases. But with that, degenerative causes where the disc gets smaller with time in terms of its height. Another way I explain that to folks is if you have a car tire, and you can imagine your car tire is full of air, and if that car tire starts to lose air, the sidewalls bulge out, and when that bulges out, it can pinch on things. Well, your disc space is very similar to that. And if you have a nice full disc space that's hydrated when you're younger, your sidewalls are good. But as you lose that hydration in your disc, it starts to bulge out, and it can press onto your spinal cord and give you this myelopathy. Another thing that causes it is something called ossification of the posterior longitudinal ligament. And this is an example of that. That's where that shiny white thing that I showed you before that sits right in front of the spinal cord, sometimes that turns to bone, and it can turn to bone the whole length of the spinal canal, and then that can lead to neurologic impingement. And again, this is kind of reminds you and brings you back to that image of those bone spurs that are on the posterior longitudinal ligament. And again, that shows the close proximity of those bone spurs to the spinal cord. So another cause of it is just good old-fashioned degeneration, not only from the disc space, but posteriorly. There's the ligamentum flavum. And as that disc space goes down, the ligamentum flavum in the back also begins to buckle. And so you can get a pinched spinal cord, not only from the front, but from the back. And in this image, you can see the myelomalacia, that spinal cord signal change. Spondylolisthesis, if you have a bone that's slipping on top of the other bone, this can lead to a translation in your spine and likewise cause neurologic impingement, which leads to that myelomalacia that you can see on this image here. And if you can appreciate the step off here where it comes down, steps back, and not only does it step off in the front, but you remember the bones are a ring, and so if it slides in the front, it's also that back part, that ring, that starts to impinge on the spine. So with that, this is a patient that I took care of, SH, and we'll kind of walk through some of her symptoms and her treatment course, and we'll look at her procedure that I did for her and also her postoperative images as well. But we'll kind of start with this. She's a 65-year-old female. She came to me originally. She had dexterity issues. She was clumsy in her hands. She was dropping objects. She noted that she had progressive numbness that was in her hands, and that numbness was actually starting to go up her hands into her forearms. She had a lot of difficulty walking on grass, and that's a common thing that you'll hear is people say, hey, I feel like I'm staring at the ground more. I'm having a lot of problems walking on uneven ground and uneven terrain. Okay. She didn't have any weakness. She didn't have any pain, but she felt like her neck was a little bit stiff, right? So she had a history of a 2-level fusion there at C5 to C7. I'm sorry. Oh, there's a message there. Was that a question I needed to answer? Maybe, Tim, I don't know, but I'll just keep going for now. So physical exam, she had good strength on the exam. She has good strength in her uppers and her lowers. She did have numbness in her hands and, again, going up into her forearms. She had increased reflexes both in the upper and lower extremities, and she had a positive Hoffman's reflex as well. And I also have them do a tandem gait, that walk where they put their foot in front of each other, and she was not able to perform that. Looking at her MRI and looking at her imaging, she had spinal cord edema, or that myelomalacia that you can see right in the center of her spinal cord right here. This is where her previous fusion was, so she had developed some adjacent segment disease. Not only that, but remember I talked about that congenital stenosis, right? Having that 1-lane highway to drive on rather than that 4-lane interstate. And this is a person who has just a very small spinal canal. So any degeneration she gets, she starts to push on her spinal cord. So that's our patient. We're going to kind of go through some of the symptoms and what I look for when I'm talking to people. And I take a detailed history with them, right? I'm looking for things like gait instability. Are they talking about falling? Again, are they staring at the ground when they walk a lot? Are they having difficulty walking on uneven ground? And all of that's because the walking on uneven ground and things like that is because the proprioception from your ankles and your legs, that kind of tells you where you're at. And with myelopathy, you have a block in your spinal cord, and those signals aren't getting up to your brain, right? So you really rely on your eyes to tell you where you're at in space. So that's why people tell you, hey, I'm looking at the ground a lot more. Upper extremity symptoms, they say my hand just feels useless. I have poor penmanship. Maybe they're struggling doing buttons. They're dropping more and more objects. And really muscle weakness and atrophy is kind of a late finding in this. For the most part, early on, strength is preserved with people who have myelopathy. Another interesting thing is if you listen to people sometimes say, hey, I'm looking down or I'm looking up, and I get this sharp electrical sensation that goes up and down my back, sometimes into my arms and my legs, and that's called a Laramie sign. And that's something that when I hear that, I'm obviously quite concerned for spinal cord compression. And then people also say in different neck positions, they may have some numbness, that if they look up, they have numbness that starts going into their hands. And so that's Cosmo Kramer, and I'm always reminded he kind of looks like a myelopath when he was walking there. So physical exam, I have everybody do a tandem gait. This can be tough because people have hip problems, they have knee problems, and sometimes it's just hard for people to do a tandem gait. But you can kind of get that feeling when you just ask them to try, and you can see the way they're walking, whether it's kind of a wide-based gait, if they're struggling ambulation-wise, and if they can't do a tandem gait, that's a good sign there's something going on. Romberg's, very important test, because that's something everybody can do. You can put your legs together, put your arms out, and if they look like they're swaying and they feel like they're going to fall over, that's a good indication that their proprioception from their lower extremities is not coming properly up to the brain to tell them where they're at in space. Reflexes, very important. Reflexes, they don't lie. That's something that I pretty reliably, if I find asymmetric reflexes, if I find hyperreflexia, if I find clonus or some of these other pathognomonic, the Hoffmans, the Babinski, those are things I really key in to say, yeah, I think we need to look into your neck and look for something else that could be causing your symptoms. So the first step is x-rays for a lot of these conditions. And this is an x-ray on the right that shows a fairly large spondylolisthesis in this gentleman at C4-5, where he slips right here. And so x-rays is very important to look for slips. It can look for just a whole host of different conditions, and we get a lot of information from x-rays. The MRI or another advanced imaging study like a CT myelogram is really needed to make this diagnosis. And on the MRI, you can look at different diameters, whether it's normal at 17 or down to that congenital stenosis being less than 13 and down to 10 when it's absolutely stenotic. The MRI is great for showing us myelomalacia. We need that MRI to show us that edema. CT myelograms won't show us that, but the CT myelogram will show you the stenosis. And then, of course, if people do have that myelomalacia, that usually means they have a spinal cord injury already. So that's something I tell people is once you have that, it is a spinal cord injury, and it does tend to have a poor prognosis for recovery once you have that. So this is this gentleman's MRI where you saw his x-ray where he was slipped, and then taking that next deeper look into it with the MRIs, you can see where he slipped forward. And I've showed you this image before with the posterior elements sliding forward and pinching on the spinal cord there. So natural history. Patients absolutely love us when we can tell them what the future looks like, right? And that's really, at the end of the day, that's what people want from us. They want to know what's going on and how is this going to change in the future, and what can I do for it, right? So there's a lot of great studies. It's a very historic condition that we've looked at a lot. Clark and Robinson had kind of a landmark study back in 1956, and they had 120 patients. And the most important part is 75% of them showed a stepwise deterioration in their function. So that's why when I see people like this, I tell them, you can do well for a long period of time. It could be a short period of time. I don't know how long that period of time is going to be, but I do know that at some point your function is going to go down. And it's going to be something like you get clumsier in your hands, you're having more difficulty walking, and then you do fine for a period of time, and then you notice something else. So it's going to be that stepwise deterioration in their function over time. Lees and Turner, they had 44 patients they looked at, also showed that stepwise deterioration in their function. And an important part of this is they showed that people that had severe myelopathy did not get better on their own. This isn't a condition that's going to be treated with conservative treatments successfully in terms of alleviating people's disability. Nurek, kind of a famous study, he had 36 patients were treated non-operatively, and he really looked for different prognoses and symptoms that we could correlate for prognosis. And severe symptoms in advanced age obviously did the worst in this condition. So a little more with the natural history. CSRS, Cervical Spine Research Society, that's really la creme of la creme. That's our very best cervical society in my mind. And they really do a nice job with studies, and they have a great board that sits and puts these together and funds them really in a non-industry manner that really really puts out great research. And so they had a multi-center, non-randomized study. They had 43 patients in it. 23 of the patients had surgery and they had improvement. 20 of them had non-operative and they had increasing disability. So it really just supported the previous body of literature that shows that this is really a condition that needs to be treated surgically with decompression of the spinal cord. Okay, so the goals of surgery, that's to stabilize your neurologic function, and recovery depends on a lot of different things. How long has it been going on for? Typically, symptoms less than a year tend to do better, and if it's been going on for longer than that, people tend to do less well. If you're younger, if you have symptoms on one side, those are all things that kind of outline a better recovery for you. And also gait. Typically, gait does get better. Of course, I tell people my goal is to maintain your neurologic function. I hope is that you get better. But we really want to prevent you from getting worse by intervening and doing something about this spinal stenosis that they have. So again, the goal of surgery, decompress the spine. If it's unstable, we want to stabilize it. And we also want to restore their alignment and give them that proper curvature of the spine, help with their pain and their deformity, right? So the approach is going to be based on a number of things. Where's the stenosis at? Do they have pain? How many segments are involved? So really briefly, I'm just going to go through the different approaches for it, and I won't belabor this too much, and I have a whole host of examples that we can go through the imaging at the end. But basically, the one approach to is going from the front of the spine, and you can decompress the spinal cord, you can decompress the nerve roots. Typically, you can treat 3 levels in an isolated front approach. You could do 4 levels or even more than that, but you would have to incorporate a posterior approach as well. Going from the front, you can correct their alignment, their kyphosis, you can fix instability, and the different surgical options for that would be your standard anterior cervical discectomy and fusion, or ACDF, and another one is the corpectomy, where the difference is you go in an ACDF and you would just take out that disc to work through that windowed space to clean out around the spinal cord. And with the corpectomy is you actually take out the entire vertebral body as needed. And then you actually take this bone off back here too to decompress the entire spine. And then cervical disc replacement is an option if you have a young person that has a disc herniation with myelomalacia. Posterior approaches. A lot of different options here for congenital stenosis. This is really a good one. If you have more than 4 levels that you need to address, if you have that ossification of the posterior longitudinal ligament that we kind of showed before, where the bone has developed the whole way down, and then surgery options, laminectomy, laminoplasty, and I'll show you some examples of that. So I've talked about surgery, but there is a role for conservative care for this. Some people, if you're in your late 80s, 90s, there are people who have stenosis and they say, hey, I'm doing okay, I'm getting by, I don't want to do surgery for this, and that's entirely fine. And there's a good chance, remember that stepwise decline in function, they may outlive their disease process when it comes to this, so they may not need surgery. So you can always try anti-inflammatories if they're having pain. Sometimes just some isometric exercises with therapy can alleviate some of their symptoms. Cervical orthosis, they had 50% improvement in gait function with that Clark and Robinson study that we talked about. But the really important thing here is careful and close follow-up. So I have several people that have myelopathy and they say, I'm not bad. I'm not really severe yet. I don't want to do surgery for it. And I say, that's totally fine. I say, if you want to wear a collar, we could fit you for a soft collar. You can use that when you're being active or out and about. And then I also try to see them back at 3 to 6 months and just to make sure they don't have any neurologic changes. And if that's something their primary care provider feels comfortable seeing them back for those neurologic checks, that's something that's also something to be considered. So, but keeping in mind that if they do have severe stenosis, it's unlikely to improve. So this is back to the patient that we talked about earlier. Again, she came with numbness in her upper extremities, dexterity issues, and issues with her gait. So this is her MRI on the left. She had those 2 levels of stenosis above. And what I did for her is I started in the front, and I actually went in and took 2 disc space out and put inner bodies in there and decompressed from the front. But with her congenital stenosis and stenosis behind the vertebral bodies as well, I also went in and from the back. So I flipped her over and went in and performed a laminectomy. And this is an en bloc laminectomy where I went basically from this line down to this line and took all of this off in one piece, and that piece is here on the towel. And now this is looking down into the surgical field with the head right here. And you can see this is the spinal cord. It's all very nice, decompressed, and really plumped up. And I tell you, that's one of the most satisfying things, and you're able to lift that off, and you just see the spinal cord just expand and lift up into that area that it's now freed. This is her post-op images. You can see her previous ACDF with the plate before, the 2 levels that I did above, and then the instrumentation in the back. So with that, I just have several examples here that I was going to go through and kind of share with everybody. And each one of them kind of has a cool point to it too that I'll try to convey as we go through in a learning point. So this is a gentleman that I saw, and he came to me in clinic, and he had a month-long of unilateral weakness, numbness in his body. He was in a wheelchair, and I thought he had a stroke. I said, I think you had a stroke. And he said, no, I went to the ER, and they did a CT scan, and they said I didn't have a stroke. So I said, okay. So I got an MRI, and sure enough, he has severe stenosis right at C1. And he has a pseudotumor formation from instability at that level. And that's all this black right here. This is his posterior arch of C1. And then this is the white in his spinal cord right here. So he really has such severe stenosis that he just might stop breathing. It's so high and it's so stenotic, okay? This is his x-ray. You can see that he's got that slip there. And so what I did for this gentleman is I went in and decompressed his spine, first of all. And this is C1 up here, and I cut the back part of his lamina off. And then I put a plate into his head right here and attached him into his cervical spine. And these segments were kind of already prefused in this gentleman, but this is really the important part, decompressing his upper cervical spine there and putting that stabilization for him. And you look at these images, and you're like, oh my gosh, he has no motion in his neck left, right? He can't look up, down, he can't look side to side. So, I mean, I spent probably a half an hour taking x-rays and just positioning his head in the perfect position, because that's the way he's going to be for life, right? And so you look at that and you think, gosh, that's a lot of hardware. But remember, this guy was in a wheelchair when he came to me. And if you can't walk and then you can walk after surgery, you really don't care if your head turns or not. So he was really happy to have his long strides back again. So another example here. This is a gentleman who has a spondylolisthesis. I kind of showed you those images as we went through the presentation. You can see he has spinal cord stenosis here. He has that big slip. But not everybody needs that big surgery. This was successfully treated with just a 1-level ACDF, where I went in and took out the disc, put a inner body there, and put a plate on, and he did well with that. This is a gentleman, great learning point. This is a guy who had no known myelopathy before. He had a hernia, went in, had his hernia repaired, woke up and had clumsiness in his hands, and his arm wasn't working very well. And he saw me, I got an MRI of his neck, and sure enough, he had spinal stenosis right here. He has kind of probably a degenerative disc with maybe a little bit more of a herniation at that time. But it's something that nobody would ever know. He didn't have any symptoms prior to his hernia repair, but at some point, possibly with the intubation and neck extension and things like that, he started to develop some symptoms. So for him, I went in, I did a 1-level ACDF, and about 3 to 6 months later, he had function back in his hand and did really well. So the point I wanted to stress with this is the people that I do know that have cervical stenosis and choose not to do anything about it. I write on a piece of paper for them. I say, hey, I have spinal stenosis, and if you're going to have another procedure, get intubated, you need to let the people that are taking care of you know that, so they can do glide scope intubation and things like that, so they know not to extend your neck. So another gentleman I saw, he had numbness in his hands when he looked up. No symptoms at all, but he looked up and he got numbness that went into his hands. I think he had a little bit of clumsiness, but not bad. So I got this MRI, looked at his looked at his MRI here. You can see he has a big disc herniation. He has some myelomalacia, and this image here is the disc herniation that's displacing his spinal cord. And I just put this as a normal slice so you could kind of compare what a normal slice looks like with the spinal cord here and the CSF around it as compared to this with that herniation into the spinal cord and displacing it. So there you go. Successfully treated with an ACDF, just a small one-level procedure, and he did well. This is the gentleman who had multi-level disease, and you can see he has myelomalacia or spinal cord signal change right here from every level basically is pinched between his congenital stenosis and his disc degeneration. And so this is a procedure called a laminoplasty that I did, where I went in, and basically this is a non-fusion surgery where you go in and you just lift up the back part of the spine, that lamina, and you put a plate in, and that keeps that area open and decompresses their spinal cord. So this is a gentleman that I saw in clinic here, and he initially had a low back surgery done a year before because he's had leg numbness, didn't improve anything. And he came back a year later, and I saw him here, and he had numbness now up to his chest. And he had sustained clonus in his ankle, spastic gait. And so I said to this gentleman, we need to send you over to the ER and get an MRI. So we sent him over same day, got him in the MRI machine, and we found this. Just severe cervical stenosis and displacement of the spinal cord. And you can see he has myelomalacia or spinal cord signal change here. And up here, he also has another level that's stenotic and behind it. So this is another image, same guy, where it just shows the amount of stenosis he has behind the vertebral body and up to here. So what I did for this gentleman was a corpectomy, and that's that procedure where you go in and you take out the entire vertebral body and you replace that with this cage and put a plate right on the front there. And at this point, his numbness has improved a lot. He has some numbness in his foot, but his gait is just significantly better. And so he's a fairly young guy. I think he was in his 40s. This is a patient that I also treated here, and she has a kyphotic neck deformity. She really has severe stenosis with osteophyte formation in these low levels that are really impinging on her spinal cord. And as you can see, if you can imagine, just going from the back and decompressing is not going to take off this tightness from her spinal cord anteriorly. So she really needed something to help address her alignment and to decompress her from the front. And this is her x-ray where you can see she's really tilted off to the front. So this is what I did. I went in and did a 4-level anterior surgery for her, rebuilt her curvature to her spine where you can see she's previously had that kyphotic deformity, placed the inner bodies. And usually when you do more than 3 levels, we just know from experience that 4-level has such a high rate of pseudoarthrosis that we go in from the back and also put instrumentation in to lead to a more successful fusion. And so that's what I did for her. So, and that's her imaging there, both from the side and from the front. One more here. This is a gentleman that one of the physicians over in Carroll sent to me. Interesting story. He really loved their local fair, and he liked to go up in the man lift and hang all the various things that they needed to hang. And he said, this year I can't do it because I dropped so much stuff. I'm worried I'm going to drop something on somebody. And so this sounded concerning, and they got an MRI, and they found that he did have really severe stenosis here. And this is his image in the middle, his preoperative MRI. And so we also got a CT scan, and you can see he has these huge osteophytes that are really impinging and pushing in on his spinal cord. Okay, so as part of his treatment, I kind of looked at doing both a procedure from the front and the back, and really tried to weigh out the different options for him. And ultimately, what I did is I decompressed him from the back and fused him, and thought if we need to do more to build his alignment, I can get a post-op image and come back and do that if needed. But that's why I got this second MRI on the right. And you can see after his decompression and taking that lamina off, he really just has beautiful space for his spinal cord. It's nice and open with these white lines, CSF fluid, both in front of and behind his spinal cord. So that was all we did for him. And he's had a really, really great recovery. So important points that I wanted to cover as we kind of conclude here is if you know somebody has cervical stenosis, we can follow it clinically. We can see them back every 3 to 6 months. If they are going to have another surgery, I tell them, hey, make sure you talk about glide scope intubation, not extending their neck. I do recommend avoiding any manipulations or adjustments of the neck when you have this known stenosis. And even with therapy, a lot of times traction is great with radiculopathy or disc herniations, but not necessarily in the myelopathic population. And then I tell people, hey, I don't want to scare them, right? But you say, if you were in a car accident, you have a higher chance of having a neurologic deficit. You could become, you could have weakness in your legs or even worse, right? But that chance is 9%, okay, for you, versus me is 3%. So if I'm in a car accident, assuming I have a normal neck, I have a 3% chance of having a paralysis or something like that. So they have a little bit higher risk, and it's just something that I think helps convey that to them. And Dr. Friedrich has a nice thing that he tells kids that are healing with their fractures to avoid anything high or fast. And so I've adopted that now into my speaking to myelopaths that are being managed conservatively, as I tell them to avoid anything high or fast, no ladders, no fast things, right? So I think that works well there too. So other important points, balance issues. If somebody comes in to you and says, hey, I'm staring at the ground a lot more, I'm having difficulty with the uneven ground, that keys me into a spinal cord issue. I mean, it's tough sometimes to tease out vestibular issues, but typically those will be people talking about the room spinning, and they'll kind of have different symptoms. This is more a feeling where people will say, I feel like my head is disconnected from my body. They just kind of feel like they're floating. And that's actually a key one that you can kind of ask them. And oddly enough, they may not be able to articulate it, but after you say it to them, they'll say, yeah, that's exactly what I feel like. Dexterity, coordination issues, abnormal reflexes. Reflexes don't lie, right? They're subjective. Out of all the things, I love when I'm able to identify and hone in on some reflexes that help me diagnose something. Numbness that doesn't follow a dermatome, something that's important to look at because that's more of a cord level issue. Different neck positions, you're looking up, looking down, you're getting numbness or a Lhermitte sign. And then if you don't have any arm symptoms, but they're having these symptoms in their legs, don't forget the thoracic spine. We can always get an MRI there. And I tell you what, MRIs are so accessible at this point that if you're in question, the consequences of missing it or not knowing about it are pretty significant. So if you're in question, just go ahead and get the MRI of the neck and the thoracic spine. So that's the myelopathy talk. And I have another one on spondylolisthesis, but I think in the interest of time, and maybe we'll save a little time for questions, we might cover that at a future grand rounds if you guys are willing. All right. Well, thanks, guys. Appreciate it.